Apologize, Dr. Yash Lokhandwala is not able to make it, and he has sent the slides. And so we just would request Dr. Muralidharan and others to pitch in. Can we have the presentation, please? This is in the quiz format, and we'll have the ECGs, and there are MCQs at the bottom. First, this is meant for practicing clinical cardiologists to highlight some of the clinical issues which we see in day-to-day practice. So this is a 65-year-old gentleman who presents to the hospital at 8 a.m. in the morning with this chest pain, and this is the ECG. There's history of smoking and nothing else. What do you think is the diagnosis? How do we take the MCQ? These are the choices. Is it early repolarization, acute pericarditis, hyperacute inferior wall MI, or coronary artery spasm? There's concave ST elevation upward, and you see the... Now, anyway, because I thought this is going to be MCQ is going to come in. However, we'll take Dr. Muralidharan's input.
Yes. Sir, or want to go straight to it?
Yeah, you can discuss.
How many of you will go for the A? Raise your hand. B? Few of them. Hyperacute MIC? Majority of them. Coronary spasm? Rare. One few. So
okay, you got it right. Okay. So one thing is sure, whenever you see a reciprocal ST depression in AVL, you shouldn't entertain early repolarization. This is very specific for regional ischemia. And 5 minutes later, the patient said he is feeling better, and you saw the initial one was 820 and this is 836. And now this is the same patient's ECG. Now what is the diagnosis? And another 5 minutes later, 840, again this has happened. So one thing I would like to emphasize is, Dr. Murali.
Like you already point out, I think some of them, we see the ST chaser evanescent comes and goes, not a typical feature of a pericarditis or early repolarization. And MI in evolution or a coronary spasm, both will be high in the cards. So careful clinical follow-up and looking at the other ECG will be helpful, sir.
Right.
Generally, this type of sudden appearing and disappearing is the commonly seen in coronary spasm post anesthetic patients. Sometimes we are seeing huge change in the ECG and suddenly vanishing. So it could be the spasm also, because generally in pericarditis it should be persistent all the and PQ segment is not changing.
Right. See, this reason why this ECG was put up was we don't think of this entity, and it does happen in clinical practice, especially compared to your Braunwald or Hurst. Coronary spasm is distinctly more often seen in Asian population. It's seldom seen in Caucasian population. The reason why this is happening is because of some of the genotypes that are common, which are associated with calcium sensitivity. Typically, these patients will have flushing with alcohol. Coronary artery spasm, usually the angina occurs at rest, frequently early morning or at midnight. Majority of them have minor atherosclerotic plaque. One other substrate is it can be postprandial. And during ischemic episodes, some of them may have a transient mitral regurgitation. And specifically, this entity becomes worse with beta blocker. Now, the other subset of patients, it's not mentioned in the slide. Whenever you see following Holi or Diwali, a youngster coming with chest pain and ST elevation, this we have seen quite a few when they use substances. Typically, patients will be tachycardic, there will be a pupillary dilatation, flushed, and the amphetamines are used as substances, and they are known to cause this problem. So in Asian population, this accounts for 10 to 15% of patients with angina, And sometimes there may not be significant ECG changes which are dynamic because of several modifying factors like collateral perfusion, pre-existing wall motion abnormality, and simultaneous spasm in different vessels. Simultaneous spasm, we have seen patients who again snort cocaine. So typically they'll have nasal abnormalities, running of the nose. I'm sure some of you would have seen this is reported from UN study, has reported a very high prevalence in certain states like Northeast and Punjab in India. The substance abuse is fairly common and they can have this kind of a problem. The main thing to understand is ask leading questions. Do not use beta blocker. The drug of choice is nitrate and calcium antagonists for these patients. And people who use ergot and migraine medications again have an excessive tendency for coronary spasm. There's history of migraine, you should think of this entity. Now, this is a diabetic hypertensive with CKD, presents with significant fatigue, has been on diabetic medications with metformin, and for blood pressure is on metoprolol XL, statins and antiplatelets for possible coronary disease, and torsemide for decongestion. He comes with this ECG. The choices are hypothyroidism, pericardial effusion, hyperkalemia, and ACS.
Shall we go for voting?
Yes.
How many will go with hypothyroidism? Oh.
No, still voting going on.
So it's essentially between hypothyroidism and hyperkalemia. 36% and 64%. Can we go on to the ECG, please? Hypothyroidism 38. Dr. Murali?
Yes, sir.
Sir, you want to discuss?
Yeah, basically, junctional look like a P is absent here. So I'll go through the, although there is some ventricular rate is absolutely idioventricular rhythm, approximately rate is around 20 to 30, between 20 to 30. So I'll go through the hyperkalemia, I'll think.
Very right. So this is what the patients had. The choice is it's clearly hyperkalemia with a severe acidosis. We'll address, this is life-saving for this patient. I'll come to this. How would you treat this patient? Atropine followed by isopril, temporary pacemaker implantation, calcium, soda bicarb, dialysis, and both B and C.
I will go through the first. Voting? Yes.
Voting.
Voting. C. Is there voting is going on?
Yes. Voting.
No, it is not showing. So, not showing. So, I will go through the first IV calcium gluconate.
Okay.
And we'll see the immediately AVG and then accordingly sodium bicarbonate. And if it is refractory, insulin drip and followed by dialysis. This is our line of it.
So, all of you understood calcium followed by response. Look at the response, look at soda bicarb, then insulin glucose drip, and then so on and so forth. Now, this was the paradigm which was challenged by this called as Brash syndrome, which is when you have patients who have received AV nodal blockade and they come with hyperkalemia. There is an interaction between both hyperkalemia and AV nodal blockage. When the GFR comes down, the patients transiently will improve with whatever measures you have. But because the half-life of these drugs are 12 to 24 hours, they will remain in the system. They will improve. You go back and take a nap in your restroom or something, and then 2 hours later, they'll again code. So the study indicated that you need to simultaneously address, whenever you simultaneously address hyperkalemia with both whatever was mentioned in terms of calcium, soda bicarb, insulin glucose, dialysis if required, and temporary pacing support, the outcome is much better than sequentially doing one after the other and looking at the response. So that is an important change in critical care literature which had come out, that whenever you have a person with drugs on board, especially XL preparations, long-acting preparations, you should immediately go in for all the measures to be taken simultaneously instead of sequential management of these patients. And once that was corrected, this patient's symptoms significantly improved. Now, this is a patient who was seen apparently in JJ Hospital with pulmonary COX, diagnosed a month ago, presents with vomiting and nausea, admitted with near syncope, 65-year-old lady, diabetic and hypertensive. And this is the electrocardiogram. Unfortunately, the patient received IV amiodarone. Next slide. This patient received IV amiodarone bolus, and the whole thing worsened. You can see the T wave merging into the next T wave, the QT grossly prolonging. So whenever you have polymorphic VT, torsades, QT prolongation, please look at the QT and avoid QT prolonging drugs in these patients. Patient went into a storm till such time they realized that this was due to long QT. Now what would we give? All the biochemistry is normal. Would you still give magnesium? Yes or no?
Hold on, sir. We can switch on this.
Dr.
Yeah.
Murali?
Yes, sir. No, the polling is still going on.
Yeah.
So mostly agree with to, yes, we have to tip.
We have to
You have
give
to.
magnesium, sir, whatever the situation is.
So the main reason to put this up is irrespective of your serum magnesium, you should give intravenous magnesium for this patient. In fact, most of the studies have indicated that you get suppression of these polymorphic VT at a serum level of 3 milligrams to the point when you see that tendon reflexes come down. It is at that level you suppress this. So most of the magnesium is stored. Next slide, please. After lidocaine bolus, all the polymorphic VT disappeared, but however the QT remains prolonged, and following slowly the treatment, everything, the QT resolved and the patient improved. So this is very common when you use drugs which cause hepatic impairment or renal impairment. The liver enzymes go up. With that, the clearance of the enzymes and the drug levels go up, and they can result in torsades. The new drug bedaquiline, which is used again for multi-drug resistant tuberculosis, can cause this. So the risk factors for drug-induced torsades includes more common in women, patients with structural heart disease, people with borderline hypokalemia, bradycardia, their underlying long QT, multiple QT prolonging drugs, and hepatic impairment. One thing we forget is a common drug we use is pantoprazole. Pantoprazole depletes and decreases magnesium absorption, and it's well known to cause magnesium deficiency. Along with that, when patients are commonly, you ask physicians, most of them will not tolerate rifampicin. They'll come with nausea, vomiting, and we give domperidone, and which again prolongs the QT. This combination is very often used along with antituberculous therapy, which is known to cause QT prolongation. So magnesium is the drug of choice regardless of serum magnesium, and most of the magnesium is intracellular and maximum is stored in the bone. Serum magnesium is not reliable, and usually in this patient they coexist with hypokalemia. So you give a bolus of intravenous magnesium irrespective of serum magnesium. If patients develop recurrent torsades, you run it at about 3 to 5 milligram per hour as a drip continuously. This is the next ECG, 74-year-old man, normal health with history of syncope while climbing stairs. What are the choices? Sinus node dysfunctions. Can we stay on the ECG for a while, please?
Go back to the
Sinus node dysfunction,
second degree AV.
second degree AV block, or complete heart block. Can go to the questions now. No, second degree AV block doesn't come up in the thing.
The choice is not given.
It
Second
is
AV
there
block
in
is not there.
They have typed it
It is
wrong.
not complete heart block. Yeah, yeah.
No, that's okay. One of you can discuss,
Yes, sir.
please.
Want to say?
Yeah.
Next.
See, going back, we can see a group beating, sir. We can see
Yes.
the P wave,
Followed
first
by-
P wave getting conducted.
One-
Second,
this is
saturation, there could be a
non-conducted.
mild prolongation of white quarter. The third P wave is not conducted. So 3:2 conduction, with the white QRS. But I would like to draw the thing. If anybody gets it looks like there may be mild prolongation. But the chance of it being an advanced AV block or infranodal is very high likely with the white QRS.
The variable AV block is going on, and sometime 3:2:1 block, but RR is highly variable from it. So initially looks like a 6 sinus, but if you'll see the
No,
lead,
PP interval is
yeah,
normal. PP
yeah.
interval is normal. It's not 6 sinus in the
So
thing.
second degree AV block possibility is more.
This is again sent by Yash, 51-year-old man with hypertension, past history of CVA, comes with fever, diagnosed to have malaria, received artesunate, and then episodes of rapid palpitation while in the hospital, self-terminating. And this is the ECG. Is it typical AVNRT, atrial flutter, or it's a long RP tachycardia?
Can you open the poll?
Ulas. Come. Typical AVNRT 40%, long RP 40%, atrial flutter 20%. Can you go back to the ECG? How do,
Go back to the ECG. Go back. Yeah.
right. Ulas? I don't know. This.
Yeah, because I think this is typically Yash's ECG. Yeah, I know. I think
Mike. So the basic thing is any of these febrile episodes can trigger atrial and AV nodal re-entry. The main thing is this is not typical AVNRT. In typical AVNRT, the P wave becomes hidden within the QRS. Here there's a long RP. This is a R wave. The P wave is very long RP tachycardia. They tend to be sometimes incessant and can lead on to LV dysfunction because of a very slow retrograde conduction. But I don't know what the artesunate, as Dr. Ulas was saying, we didn't realize what the importance of artesunate was. But nevertheless, this is the ECG.
Yeah.
So long RP tachycardia, the importance is it can be incessant and very often the rates are not very rapid. So the patients never complain of palpitation, they silently go into heart failure as the presenting manifestation. And after correction. This is a 54-year-old person who comes to the ER with chest pain. ECG shows early repolarization variant, pericarditis, non-STMI, or it's an acute MI. Allow the ECG for about 10 seconds at
Can
least.
you go for the poll?
Is there on the poll question? Yeah. So early repolarization variant, pericarditis, 40, 30, 30. So there's an even spread.
Yeah.
And let me go back to the
Maybe we can go back to the...
Dr. Murali.
Yes, sir. Here, I mean, among the choices, if you see, one thing is very clear. The inferior leads, though they are subtle, there is an ST elevation with T inversion. You can see the early MI pattern. And go to the AVL, you can see a subtle ST depression, reciprocal change also. I will vote for acute coronary syndrome, acute inferior MI.
So this patient should not have been labeled as early repolarization syndrome. First of all, early repolarization syndrome is predominantly seen in the mid-lateral leads. And whenever there is a suspicious ST elevation, I agree, we are not sure. Okay? When this patient comes to us, we are not sure that it's an MI or not. Whenever you are not sure in an inferior MI, questionable ST elevation in inferior leads, the lead to go to is AVL. Skarlovsky and Birnbaum several years ago published the importance of AVL in inferior wall myocardial infarction. Whenever there is a minor ST depression in AVL, that ST elevation is always significant. So the AVL ST depression, if it's even 0.5 millimeter, that makes the ST elevation as significant in inferior leads. So this patient has an early onset of ST elevation in inferior leads, and this is an inferior wall myocardial infarction early on in the stage. But Okay, all of us agree that there is a situation when in the casualty we are not sure. When you are not sure, the safest thing is please do not discharge the patient, keep the patient in the hospital, treat it as an ACS, repeat the ECG after 20 minutes. Usually the changes will be dynamic. But one thing that tells you that this is specific is lead AVL. I would suggest all of you to go back and look at that reference by Birnbaum and Skarlowski, where they are in Israel publication, very nice publication about the specificity of AVL in inferior wall MI.
Very typical, sir.
Yes, Dr. Ulas, Mike, please.
I just was thinking, among the choices, instead of acute MI, it should have been written as STEMI, because non-STEMI is also acute MI.
Right.
So it's
STEMI.
it should have been in STEMI.
STEMI, no problem.
Yes, sir, but typically if you closely watch the 2, 3 and AVL 1, V5, V6 pattern of reciprocal early depression with the MI. So it is a clear cut. We have to watch clear cut 30 minutes onward, serial ECG, trop T level,
Sure.
and then we have set.
Sure. Absolutely. So this has been blown up to show the difference that the AVF shows an ST elevation and there is a horizontality and depression of the ST segment compared to the TP segment. There is an ST depression in AVL, which confirms the diagnosis. This is actually one of a physician's wife, psychiatrist practicing there, and had a syncope and came to us with this ECG. What you're seeing is lead 1, 2, 3, AVR, AVL, AVF, V1 to V3 and V5 to V6 here. So this patient comes to us with a history of frank syncope and a little injury to the forehead. And how would you proceed? 57-year-old lady, and echo is normal, angio was done outside, was normal. She was recommended a pacemaker, and then there were some queries. Someone said the EP study, someone said do an loop recorder. How would you proceed with this patient?
Voting, please.
Voting?
So no voting. So we'll go for this patient fascicular block with episode of syncope and 57-year although angio is absolutely normal. So we'll ideally go for EP and followed by pacemaker. But definitely patient required pacemaker because of the bifascicular hemiblock as well as if you'll see V1, V2, V3 and few ectopics are coming. So it is a fascicular block with.
Yes, sir. I agree, but few things are point of concern. One is the QRS, which shows something like intra-auricular conduction disturbance, particularly if you go to V1, there's a tiny Q wave with RB pattern. And the VPCs, if you see, the morphologies are not same. I'm not very sure even the coupling intervals are same. So I'll be worried about the VPCs, the focus of origin may not be one or multiple. There may be myocardial disease, there may be scarring. So I like to have more information on this patient before proceeding for a definite treatment. Sir. Imaging may be a better option.
Okay, let me just, you're absolutely right. So one is whenever you see more than one morphology of PVC in a strip, this is called pleomorphic PVC. You see one morphology, it is completely, this is a rhythm strip, right? Completely upright, somewhat different. Again, this is also a PVC. There are 3 different morphologies of PVC. Secondly, this is not a typical bifascicular block. In a typical bifascicular block, you have an R, initial R. This is a QR. QR in B1 generally suggests that there is a scar or an inflammation in the base of the septum. So I have amplified this. If you look at this, if the initial depolarization of the ventricle is through the fascicle, the rapidity of conduction will be so rapid that the QRS will be like this, sharp. Whereas here, if you look at this, it's like a delta wave. Do you see this? It's like a delta wave, which suggests the muscle around that area is diseased and there is a slow conduction. So this patient has a bifascicular block, atypical bundle branch block with a septal Q wave, three different morphologies of the PVCs, everything suggesting that there is a basal septal involvement, and this patient turned out to have sarcoid. Now, the reason why this is important is right bundle branch block is a strong predictor of a sudden cardiac death in patients with sarcoidosis. Over a period of 5 to 8 years, when you follow up, sarcoid patients don't have bradycardia alone, they die of VT. So the whole treatment changes. Imaging, if it confirms sarcoid, then you're going to give her an ICD rather than a pacemaker. So this patient turned out to have sarcoid, proven sarcoid. So this is a patient who was in the ICU, admitted for urosepsis, hypotensive, was started on antibiotics, started on fluids, NORAD, and then this rhythm strip was recorded. How do you treat this polymorphic VT? With IV amiodarone, with the magnesium sulfate, isoproterenol, or would you take her to the cath lab? This is on? Okay. Magnesium sulfate, 100%. Okay. Can we go back to that ECG, please?
Yeah.
No, the next one.
Yeah,
Now, magnesium sulfate works well for a QT prolongation, drug-induced QT prolongation, and then a polymorphic VT. The reason for polymorphic VT in this patient is, sir?
yeah. So,
Dr.
I
Ulas?
think, the history is suggestive that she has been treated with some kind of an antibiotic. She has been having urosepsis. She is hypertensive.
One minute. I'm sorry, we hadn't discussed this ECG.
Yes,
Look at the first P wave. It is not.
P wave, non-conductor P wave.
Yeah, sure.
Okay. Go ahead.
Yeah, so no, there are issues here. What could be the reason for this prolonged QT? And there are R and T triggering the polymorphic VT. On top of that, you also have an AV block.
So this patient, if you had given magnesium directly, remember, magnesium blocks the AV nodal conduction. Dr. Ulas mentioned the patient has an AV block. You cannot give intravenous magnesium without a backup of a pacemaker. So bradycardia itself can trigger a patient can go into polymorphic VT. So patient has an AV block. What happens here is the ventricle sees a very long period of asystole. For example, this beat was conducted here. Up to this is a very long cycle, short cycle. Long short cycle will trigger a polymorphic VT. If you abolish that long interval by pacing, that itself will abolish the polymorphic VT. So polymorphic VT, when it is due to QT prolongation, will respond to magnesium only when it is not due to bradycardia. The bradycardia needs to be treated. Here it's due to AV block.
Will you please go? No. I think the answer there is to take her to the cath lab to put in the TPI.
TPI.
Yeah. So
That's life-saving.
Overdrive pacing, that is. Yeah.
No, you are not going to take her for doing an angiogram.
No.
What I meant was,
Correct.
they thought, the audience thought, taking her to the cath lab was for an angiogram.
No.
But actually, that's the right answer. You take to the cath lab for several reasons. One of them is to do the TPI. So the answer is D, which is little.
No, the message is cath lab is not for CAD alone.
Yes.
It
There
is
are
meant to
several
learn
things
cardiology, practice cardiology.
Okay. I hope this is clear, because magnesium can worsen. If a person has an AV block, it can worsen the AV node. It acts like a calcium channel blockade. It can worsen the AV block. So this is an ECG from a GEM, Professor Hein Wellens. This is the ECG lead 1, 2, 3, AVR, AVL, AVF. All that the history says is this is a patient with heart failure, with worsening heart failure. What is the diagnosis? My God, everyone got it right. Perfect. I thought it would have been a difficult diagnosis. Anyway, Congratulations. This is a typical thing of a bidirectional VT. Anyone wants to discuss?
Yeah.
Yeah.
Go ahead.
Basically, digitally toxicity is a variety of arrhythmia is coming, and here the typical ST changes in the sine wave. What is the B4, B5, B6, yeah. And in a background of heart failure, we'll always think for the digitalis toxicity.
Okay.
Why it is not SVT with alternating?
All
Why it is not SVT with alternating?
Alternate
Particular blocks.
because typically the direction is changing both in VMI. And the QRS is typically
So if you
around
go to the
0.4.
pharmacological properties of digitalis, it's a very powerful blockade of the sodium potassium ATPase pump at the level of the entry. With the result, there is excess calcium overload within the cells, which cause what is known as calcium sparks. Calcium sparks will cause automaticity within the His-Purkinje system. How do you know it? Because His-Purkinje automaticity will be associated with a very narrow QRS ectopy. The ectopy will not be very broad like a myocardial ectopy. The ectopy, when it comes from the His-Purkinje system, will have a very narrow QRS. So the QRS width is generally 120 milliseconds to 140 milliseconds. And the configuration keeps changing because alternatively anterior fascicle fires, posterior fascicle fires. So it's bidirectional. And the rate is not very rapid in digitoxicity. It's usually about 140, 150, and it can be incessant. This is one drug which slows down the conduction but increases the automaticity. So the key here is whenever you have, it can slow down the AV nodal conduction, but it can increase the automaticity at the level of the junction, so it can present as junctional ectopic tachycardia. It can present as anterior fascicular VT or posterior fascicular VT, or it can alternate between anterior and posterior fascicle alternatively, like what you saw there, a bidirectional VT. One of the important things which gets overlooked is it can present exactly like sinus tachycardia, because the atrium can fire very rapidly, but it will be associated with AV block. So all of us have been taught whenever you have an atrial tachycardia with AV block, you should think of digitoxicity if a person is on digoxin. And what is the next thing that you do? You need to check. These are the other manifestations. This is, for example, when their patient with the anterior fascicular VT, it's completely right axis, very narrow QRS, right bundle in morphology, right axis, confirming that it is anterior fascicle that is firing. This is posterior fascicular VT in a different patient. So how do we treat this? Okay, we are using left, right, and center digoxin. The drugs that we commonly use like spironolactone, amiodarone in heart failure patients, all of them will increase digoxin levels. On top of that, on a given day, if the patient has a slightly worsening GFR, digitoxicity is likely to happen. And whenever it's important for you to recognize, because some of these patients will come with this kind of incessant tachycardia, they are automatic. So any amount of shocks will not terminate the tachycardia. DC cardioversion will not work in this condition. So it's not a theoretical exercise. You need to first, this is a typical bidirectional VT, and we treat with IV correction of potassium, and then the drug of choice is
lidocaine.
phenytoin.
Yeah,
So phenytoin is the drug that we have. Phenytoin is given, and slowly bidirectional VT becomes a monomorphic VT and then terminates. So this is the drug that we have at our disposal. But whenever you do a potassium and the potassium is high, that indicates there is digitoxicity is very severe, and those patients may need Fab antibodies or dialysis. So you have completely paralyzed the sodium potassium ATPase pump, and the serum potassium level is high. That's a very bad sign in the presence of digitoxicity.
Sir, is monoclonal antibody still available, sir? I haven't used for a long time.
Yes.
Is it available in India, sir, now?
It is available in select centers. So but though it's quite expensive, about 15 to 20,000 per vial in the thing.
What is alternative for IV phenytoin? Suppose
So you can use it. The mechanism for this is calcium sparks coming out. So the drug of choice is phenytoin. If phenytoin doesn't work, lidocaine can work. Lidocaine can work, phenytoin can work, intravenous magnesium works. This is one of the reasons why carvedilol may be better than the other drugs as a beta blocker, because it specifically blocks the calcium release, calcium-mediated calcium release. You should not give intravenous calcium because what is the syndrome? It results in what is known as a stone heart in these patients by completely paralyzing. So you should avoid giving intravenous calcium to these patients. I think, this is Yash's thing. So digitalis intoxication can cause sinoatrial SA block, AV nodal block, but it increases the automaticity by causing atrial tachycardia, junctional ectopic tachycardia, and as you said, alternating bundle branches or the fascicles, which can present as ventricular bigeminy or tachycardia.
Oh.
But the commonest side effect you will see is frequent ventricular ectopy or PAT with blocks. And those are the common ones, and any combination you can see.
and are very rarely only except MOBIS 2
Yes,
is not
MOBIS
causing.
2 is,
All type of arrhythmia except
Heavy
MOBIS
blockers.
2 never occurs in dioxin.
That's right.
Yeah.
so this is a 65-year-old man with LV dysfunction, and this is a Holter. Patient had a presyncope. Patient has an EF of 40%, and this is the Holter, 12-lead Holter. Lead 1 to AVF is here, V1 starts here, V6, and this is a Holter. So what does this right panel show? Does it show a monomorphic VT, a polymorphic VT? Is it a VF or is it an artifact? It's a split.
Quite well tied.
Split tight. The thing. Can we go back to the ECG, please? You want to discuss the panelists?
Yeah, so I think this is a great trace. You are investigating a gentleman, 65-year-old, with an LV dysfunction, and he had a syncope. And on a resting ECG, you have a risk marker. You have a risk marker, and that is ventricular bigeminy. And now I think you are investigating him, whether that was because of a ventricular arrhythmia. And you advise a Holter, and there you are. You know, there's something appears to be very, very rapid, broad QRS, regular tachycardia. In the background of bigeminal PVCs, severe LV dysfunction, history of a syncope, well, unless proved otherwise, this is a VT or a VF. However, this is a 24 hours Holter trace. The Holter trace is very vulnerable for artifacts. So anytime, whenever you find such kind of a very frightening arrhythmia, you should also think about an artifact. And how do you rule out an artifact is to see what is happening before that. Before this regular, frightening, wide QRS, very fast tachycardia, you see there are sinus beats. But how is the isoelectric line? It is absent. There is an undulating baseline. That itself is a sign that is an artifact. Maybe there has been some movement over his chest, and that has become little more, and then that has led to more artifacts, more significant artifacts. Now, how do you really know? Because this is a life-threatening situation. You will have to recommend an ICD probably for him. So how do you know that maybe the initial part was an artifact, but the latter part, which looks very frightening, could be actually VTVF. Now, how do you discriminate? You will have to go by the RR intervals wherever it looks very prominent and very, very clear. For example, the first 3 beats of V1, V2, V3, I think they are very clear. Yeah. Yeah. Yes. So there are
Go back in time exactly.
Yes.
You come to one QRS buried within this. It's called as a spike sign. Spikes happen within the artifacts, and the spikes are the two QRS. This one spike here, one spike here. You go back, there's another spike exactly at the RR interval. So this is an artifact. As Dr. Ulas was saying, before the artifact starts, the baseline wandering and noise has started. See, here the baseline is very clear. Here you see the noise has started. One of the electrode or indifferent electrode is picking up a lot of electrical signals, but through that you can see the QRS. So this is actually an artifact. Patient doesn't need anything.
Similar ECG we are getting in our wards, particularly for the Parkinson patients who are trembling, and we are telling sister to do the ECG. All of a sudden, very alarming, same type of things. So always thinks that whether they are having this type of vibratory movement, because automatically associated movement lead to this type of artifact. In Holter also, patient is moving here and there. We are getting lot of this. We have to check further. Discard this type of thing before you are signing the Holter report. Yeah.
I think, any other, I think we'll stop with this. Localization probably is not an important thing. We'll stop. Are there any questions? Like, none of these we are free to discuss, and we have just given a framework to recognize and think of some things which happen in real practice, but we don't pay attention to. One is coronary spasm. As we highlighted, what are the substrates? Young women occurring early morning, patients with migraine, patients who have been on calcium antagonists for something else, and there's an abrupt withdrawal. Alcohol, polyvascular spasm is common. Patients on chemotherapeutic drugs, and patients with digitoxicity. So these are some of those things which we see in practice, but you need to frame the question right so that you can suspect and treat them appropriately. I would like to thank all my panelists and all of you for the patient listening. Thank you.
And